ലിയ കേൾക്കാമോ?
കേൾക്കാം മാം.
54 പേരെ ആയിട്ടുള്ളൂ. തുടങ്ങട്ടെ?
സ്റ്റാർട്ട് ചെയ്യാം മാം.
അറ്റൻഡൻസ് തന്നേക്കണേ. So last class we discussed about the obstruction of the arterial circulation, central retinal artery occlusion. Today we start with the obstruction to venous circulation. So the last class we discussed central retinal artery occlusion, the predisposing factors, the carotid artery stenosis, the embolus, then valvular heart disease, like that. In venous obstruction, as you know, hypertension, hyperlipidemia, diabetes, and a local ocular factor, that is a raised intraocular pressure, which is very commonly associated with obstruction to venous circulation or central retinal vein occlusion. So what all investigations you have to do in such patients are, you have to record the blood pressure, you have to take an ECG, blood count, ESR, fasting blood sugar and lipid profile, because it is more commonly associated with hyperlipidemia and diabetic. And if central retinal venous occlusion occurs in young patients, you have to do some specific investigations to rule out multiple myeloma and other polycythemia vera, like that. That is in conditions which produces an increased hematocrit value. So now I come to the central retinal vein occlusion proper. We classify the central retinal vein occlusion into two types, non-ischemic and ischemic type. Even though the ischemic type is rare compared to a non-ischemic type, the complications are more with ischemic type. So we have to differentiate a non-ischemic type from an ischemic type. Ischemic type responsible for only 25% of the total central retinal vein occlusion, and a non-ischemic type about 75%. In both conditions, the patient presents with a painless, sudden loss of vision, but the defective vision or the visual acuity is markedly impaired. That is just like a comparison between non-ischemic and an ischemic type. In ischemic type, patient will present with a usually sudden loss of vision, and the defective vision is very marked up to the level of hand movements or counting fingers close to face. But in the other condition, that is non-ischemic central retinal vein occlusion, it is just a blurring of the vision, and patient may have a 6/9 to 6/12, 6/18, like that. So there may not be an afferent pupillary defect or an RAPD, that is a relative afferent pupillary defect in the affected eye, and in non-ischemic central retinal vein occlusion, and even if it is present, it is only mild. And fundus pictures are so the fundus is affected, and you can see, if you remember the normal fundus, it is almost this, just like this normal fundus is. This is actually this case resolved to this stage, but you can see the optic disc is like this normally also. But in patients with the non-ischemic central retinal vein occlusion, you can see any fundus we describe in terms of optic disc, the size of the disc, the shape of the disc, margins, whether it is edematous, and the retinal vessels and the entire retina. So if you describe the non-ischemic central retinal vein occlusion, instead of the normal disc, you can see the disc is edematous, and you can see the margins are ill-defined or blurred disc margin because of the retinal peripapillary retinal edema and optic disc edema. And you can see the retinal veins are very much dilated and tortuous, and you can see plenty of flame-shaped hemorrhages, which starts from the disc margin extending well up to the periphery beyond the equator. And you can see so many exudates, that is yellowish, white fluffy lesions. They are called as soft exudates. So that is a fundus picture in non-ischemic CRVO. The veins are tortuous, dilated with a dot and blot hemorrhages, and also flame-shaped hemorrhages, cotton wool spots, optic disc edema, and in some situations there may be macular edema. And involvement of the macula by the edema and hemorrhages can produce marked impairment of the vision, and the prognosis is variable, and the treatment also is inadequate. You have to treat the underlying condition like hypertension, hyperlipidemia, diabetes. And if there is a raised intraocular pressure, that is in primary open angle glaucoma, which is associated with central retinal vein occlusion, you have to treat the glaucoma part also. And if the patient is suffering from macular edema, you have to give intravitreal anti-VEGF or antivascular endothelial growth factor or triamcinolone. So that is the only treatment which is available. And compared to the non-ischemic central retinal vein occlusion, all the findings starting from the defective vision to the fundus findings are very marked compared to the non-ischemic central retinal vein occlusion. You can see the visual acuity is very much reduced, like counting fingers close to face or worse, and the afferent pupillary defect is very marked, or there is a relative afferent pupillary defect which may be absent or mild even if it is present in non-ischemic central. And the fundus findings compared to the non-ischemic, here it will be disc will be severely edematous with severe tortuosity and dilatation of all the branches of the retinal veins, with extensive retinal dot and blot hemorrhages and flame-shaped hemorrhages involving the macula and extending up to the periphery, and disc edema and macular edema will be marked. And there is signs of ischemia in the presence of denoted by the presence of multiple cotton wool spots. And the treatment of why you want to differentiate a non-ischemic from an ischemic CRVO is ischemic CRVO can lead on to complications like neovascularization of the anterior segment in the form of neovascularization of the iris, otherwise called as a rubeosis iridis, or neovascularization of the angle, which later can lead on to neovascular glaucoma, which is a very painful condition, and the patient can lead on to develop a painful blind eye. So in order to prevent these complications, and in some situations a patient may improve the vision also. So mainly to prevent painful blind eye, we have to treat an ischemic CRVO, and close follow-up of the patient is needed in ischemic CRVO compared to a non-ischemic CRVO. And one other thing is a non-ischemic CRVO, if you follow up, the patient can develop into ischemic CRVO also. So monitoring the patient closely is very much needed both in non-ischemic and ischemic CRVO. Non-ischemic CRVO, whether the patient is changing into ischemic variant, and ischemic type follow-up is needed to assess the development of rubeosis iridis or neovascularization of the angle leading on to neovascular glaucoma. So I have written that rubeosis iridis develops in 50% of the cases and progress into neovascular glaucoma. So you may get questions like draw the fundus picture of central retinal vein occlusion. So you can classify into ischemic and non-ischemic, and you can draw the fundus picture. You can get questions like causes of rubeosis iridis. The first and foremost cause is central retinal vein occlusion, or both proliferative diabetic retinopathy and central retinal vein occlusion. Almost equal causes for neovascular glaucoma or rubeosis iridis. So these are all. You may get some short notes on neovascular glaucoma or rubeosis iridis, 2-mark question or 3-mark question, or even 1 mark question that is mentioned 2 causes of neovascular glaucoma or 4 causes of rubiosis iridis, like that. Okay, so in that situation, you have to write central retinal vein occlusion. So this is the fundus picture. This is the fundus picture of ischemic CRVO. You can see compared to the previous picture, the hemorrhages are very large areas of hemorrhages, and this is the corresponding fundus fluorescent angiography. You can see these all black areas are areas of ischemia. Compared to this picture, you can see all these areas are you can see vascular markings, which is absent in this fundus fluorescent angiography. That means this is extensive areas of capillary non-perfusion, suggestive of ischemic central retinal vein occlusion. This is another patient with a central retinal vein occlusion. You can see you cannot make out the optic disc because of the disc edema. You can see the retinal veins are tortuous, dilated and tortuous, and you can see the extensive hemorrhages and flame-shaped hemorrhages, and you can see this whitish soft exudates also. This patient also, you can see this whitish lesions are more in this patient compared with this patient. So this whitish lesions are called yellowish white fluffy lesions are called soft exudates, and this soft exudates indirectly gives a clue that the patient has got an ischemic central retinal vein occlusion and need a close follow-up. Now I come to the next talk, that is a branch retinal vein occlusion. So instead of the retinal vein, central retinal vein at the region of the lamina cribrosa, in this case, the branch retinal vein, that is a branch of the retinal vein, which in the early class, the last class, I explained that at the AV crossings, that is where the arteries crosses the veins, they share a common adventitious sheath. So whenever the arteries are thickened, as in patients with hypertension or atherosclerosis, because of the arterial thickening, wherever the arteries crosses the veins, it will compress. The arteries lie over the veins, and if it is thickened at the AV crossings, the arteries can compress the veins and lead on to branch retinal vein occlusion. And branch retinal vein occlusion, the symptoms depends on which branch of the retinal vein is affected. So suppose the supratemporal branch is affected, it drains the superior aspect of the macula, and patient can have a field defect. And because of the macular involvement, patient can have a metamorphopsia of the macula. Visual acuity is also variable. And in that particular area of distribution of that vein from the AV crossing, patient can have a dilated, that branch of the vein is dilated tortuous, and you can see the hemorrhages beyond the AV crossing. Okay, the prognosis is good compared to a central retinal vein occlusion, and again the complications include chronic macular edema and neovascularization of the fundus. And the treatment is the same. Any condition that produces neovascularization of the retina, that can lead on to neovascularization of the retina, and in cases of macular edema, the treatment is injection, intravitreal injection of anti-VEGF. So in this picture, all this area, that is, this is an infratemporal branch vein occlusion. You can see from here onwards, that is, at this area, this is the first AV crossing. So the arteries crosses the veins at several areas, that is first crossing, and beyond that second crossing. So this is the first crossing, that is AV crossing, where the arteries compress the vein, and beyond that area you can see the hemorrhages. So it is only an infratemporal branch retinal vein occlusion. All the other areas, the retina and the vessels are normal. So this is an infratemporal branch retinal vein occlusion involving the macula. So this patient presents because of the inferior half of the retina is affected, patient can have a superior field effect. So this is another condition. You can see extensive areas of hemorrhages and corresponding fundus fluorescent angiogram. And this patient on follow-up, once the hemorrhages are resolved, you can see almost the whole area of hemorrhages are absorbed, and few areas the hemorrhages are remain. Now I come to a very important topic, that is a diabetic retinopathy. Again, you can get short note on diabetic retinopathy. You can get question on fundus picture, draw the fundus picture of diabetic retinopathy. And also, not only for MBBS purpose, that is after your in MBBS, any specialty you see, if you take a clinical specialty, or even otherwise, even if you are doing a primary, you are working in primary health center, you are in any situation, we encounter patients with a diabetes. So knowledge regarding diabetic retinopathy at any stage in our life is very, very important, and you should keep throughout your lifetime. That is, this disease is a preventable, very, very important cause for preventable blindness in world, and it is very important to screen the patient to rule out diabetic retinopathy. So why I am stressing is, so many patients are becoming blind because of the neglect, either by themselves or by the treating physician, because of the because they are not sending the patient for screening of diabetic retinopathy. That is why I am again and again telling it is a very important disease, which you should consider throughout your life, even if you are taking any other specialty, medicine, pediatrics, any gynec, orthopedics, any specialty, you encounter patients with the diabetes mellitus. So diabetic retinopathy, even if you see more of non-insulin dependent diabetes mellitus than an insulin dependent diabetes mellitus, diabetic retinopathy is more common with IDDM than NIDDM. Why? Because this type 1 diabetes or insulin dependent diabetes, it is the diabetic age of the patient and not the chronological age of the patient is responsible for diabetic retinopathy. So a patient who develops insulin dependent diabetes mellitus at a young age has got a longer diabetic age compared to an old patient who develops an IDDM at a later onset. Okay, understand? So it is the diabetic age that is responsible for the diabetes. That is why type 1 diabetes or an IDDM has got more of diabetic retinopathy than non-insulin dependent diabetes mellitus. The risk factors, the first and foremost is the duration of the diabetes. So the duration, which is the most important risk factor for diabetic retinopathy, then comes the control of the diabetes. So even if the patient is under well control and the diabetic age is 20 years, suppose a person develops 15 years diabetes, IDDM, and by 35 years of age, the patient's diabetic age is 20. Okay, so by that time, even if the diabetes is well controlled, the chance of getting diabetic retinopathy is very high. But it is compared to uncontrolled diabetes, it is less. Now, the third risk factor is pregnancy. So in patients with pregnancy-induced diabetes or in insulin-dependent diabetic patients later becoming pregnant, it is very important to do a close follow-up in patients, even if the patient is not having any diabetic retinopathy in the presenting situation. Okay. Then other risk factors include hypertension, diabetic nephropathy, obesity, hyperlipidemia, anemia, and smoking. Smoking is a very, very important risk factor for development of diabetic retinopathy. So what is the pathogenesis? What is happening in patients with the diabetes? In diabetic patients, you can get both microangiopathy and macroangiopathy, and we are worried about because retinal circulation is a microcirculation. And because this microvascular complication occurs in the retina, in the kidney and in the peripheral nerves. So these are the three areas where the diabetic microvascular complications occurs. So a patient who has got a diabetic nephropathy, it is almost 100% chance that the patient can have a diabetic retinopathy also. The renal vessels or the renal circulation behaves just like a retinal circulation. Both are having autoregulation. So what is happening is it is a microangiopathy which leads on to microvascular occlusion and leakage. So retinal blood vessels has each retinal blood vessel, the endothelium has got a support by the pericytes. So the first stage, there is a loss of pericytes. So the retinal capillary wall, the endothelium, each endothelial cell inside has got a outside support by the retinal pericytes. So in the initial stages, there is a loss of pericyte. So when there is a loss of this pericyte, that is the support of the retinal capillary endothelium, that part of the endothelium, retinal capillary wall bulges, which leads on to microaneurysm formation. So loss of pericytes leading on to microaneurysms, and this loss can lead on to a breakdown of the inner blood retinal barrier. So if there is a breakdown of the blood retinal barrier, there is leakage of the plasma through the vessel wall, which leads on to edema of the retina. And also the RBCs are also leaking. The plasma is leaking, leading on to retinal edema. The blood RBCs are leaking, which can lead on to dot and blot hemorrhages. The second change is in diabetes, there is an increased capillary aggregation of platelets and defective rouleau formation. You have studied the rouleau formation and the platelet aggregation. That is the Virchow's triad. You have learned about the Virchow's triad in pathology. So there is a defect in this, and that can lead on to a non-perfusion of the capillaries. So whenever there is a microvascular occlusion, so this capillary non-perfusion can lead on to microvascular occlusion. So whenever there is a microvascular occlusion, there is a non-perfusion. And this non-perfused retina is struggling to get oxygen supply. So there will be ischemia of the retina. And the ischemic retina try to re-establish its circulation. So it wants oxygen. So it will try to re-establish its blood supply. Initially, it will be by formation of dilatation of the pre-existing vessels, that is called as dilated connections between the arteries and the veins, that is called intraretinal microvascular abnormalities. This is the initial stages, and this can lead on to release of vascular endothelial growth factor, and later this vascular endothelial growth factor is the thing which is responsible for our neovascularization of the retina. Okay, so this is the pathogenesis that is happening behind diabetic retinopathy, that is loss of pericytes leading on to defective blood retinal barrier, leakage of the plasma, and RBCs leading on to macular edema and dot and blot hemorrhages because of the defective rouleau formation and platelet aggregation leading on to microvascular occlusion, ischemia, release of vascular endothelial growth factor, and neovascularization. So the signs in diabetic retinopathy, I told you this outpouchings of the capillary wall is seen as a red dots, that is called a microaneurysms, which is the earliest sign of diabetic retinopathy. And you can see the leakage of the RBCs in the form of hemorrhages, that is flame-shaped hemorrhages. If the hemorrhages occurs in the superficial nerve fiber layer, it occurs as a flame-shaped. As I showed you in the retinal vein occlusion, I showed you the flame-shaped hemorrhages, that are hemorrhages that occurs in the superficial retinal nerve fiber layer. If the hemorrhages occurs in the middle compact layers, that is the inner nuclear layer, it forms like a dot and blot hemorrhages. Another thing is a macular edema because of the leakage of the plasma through the capillary wall. And later this edema can lead on to chronic retinal edema can lead on to hard exudate formation. So these are a few changes that are occurring in the diabetic retinopathy. You can see this is a flame-shaped hemorrhage. You can see this is a flame-shaped hemorrhage. This is a blot hemorrhage. These are small yellowish, well-defined hard exudates. These are all blot hemorrhages. So this is a hard exudates which is arranged in the macular area in a star shape. That is a macular star. And another thing is cotton wool spots, intraretinal microvascular abnormalities, dilatation and tortuosity of the veins. So these are, in this picture, you can see the retinal veins appears as bead-like, which is very clear in this picture. So this is called a venous beading. That is, the veins appears as beads. You can see this is soft exudates. These are dark blot hemorrhages. Now I come to the classification of diabetic retinopathy and what is the significance of classification. So why we classify diabetic retinopathy is we classify diabetic retinopathy mainly for one is to follow up the patient, at what interval the patient needs follow. Suppose the patient has got no diabetic retinopathy, how we are follow up the patient. Suppose the patient has got a mild non-proliferative diabetic retinopathy, moderate, severe, very severe, proliferative, and for the treatment purpose also. So it is mainly to follow. So a diabetic retinopathy per se will not produce any defective vision. Only if it leads on to complications like vitreous hemorrhage, retinal detachment, that produces sudden loss of vision. But if the retinal edema is present in the macula in the form of a diabetic maculopathy, it is the most common cause for defective vision in diabetic patients. Posterior segment. So diabetic maculopathy is the most common cause for defective vision in diabetic patients. So classification as non-proliferative diabetic retinopathy is broadly classified into non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. So first is the mild to moderate, or you can just consider it as a mild diabetic retinopathy. Second is moderate, third is severe, and fourth is a very severe. So the first one, that is a mild diabetic, non-proliferative diabetic retinopathy, you can see actually this classification is an ETDRS classification, that is early treatment diabetic retinopathy study classification, and in this they show some pictures, and the references are regarding of this is depending on the standard textbook fundus photographs. Okay, so in mild non-proliferative diabetic retinopathy, you can just see some microaneurysms, intraretinal hemorrhages, hard exudates, and foveal avascular zone abnormalities, which is not up to the level of moderate. That is what they are saying. Very few microaneurysms and very few hemorrhages. And in the moderate stage, again, you can get some venous bleeding, some intraretinal microvascular abnormalities, but not up to the level of a severe non-proliferative diabetic retinopathy. Okay, so in severe non-proliferative diabetic retinopathy, they classify, or there is a 4-2-1 rule. That is a 4-2-1 rule. What is this 4? 4 is severe intraretinal hemorrhages in all the 4 quadrants of the retina. Okay, superior, inferior, nasal, and temporal. So if the hemorrhages involves the severe form of intraretinal hemorrhages in all the 4 quadrants, and second one is venous beading. I have shown you the beading of the veins, and if the venous beading is present in 2 quadrants, that is the 2, and the third is the 1, that is intraretinal microvascular abnormality in 1 quadrant. If any of this 4-2-1, that is severe intraretinal hemorrhages only, or venous bleeding in 2 quadrants only, or if there is an intraretinal microvascular abnormality in 1 quadrant, we can call it as a severe non-proliferative diabetic retinopathy. If any 2 of this 4 to 1 is present, then it is a very severe non-proliferative diabetic retinopathy. Okay. The next is the proliferative diabetic retinopathy. So in patients with a mild non-proliferative diabetic retinopathy, patient needs 6 months follow-up. If it is moderate, again 4 to 6 months. If patient belongs to severe, patient needs frequent follow-up, 3 months, 3 to 4 months. If it is very severe, 2 to 3 months. And if this condition is associated with a diabetic maculopathy, patient needs a more frequent follow-up. And in some cases of very severe or even severe non-proliferative diabetic retinopathy, we have to treat the patient with a pan-retinal photocoagulation, depending on the condition of the other eye or whether the patient cannot come for follow-up later. So suppose the patient has got a very severe non-proliferative diabetic retinopathy in one eye, and the patient lost the other eye due to complication of diabetic retinopathy in the form of a advanced diabetic eye disease, that is a neovascular glaucoma, traction retinal detachment, or vitreous hemorrhage. You have to treat prophylactically very severe non-proliferative diabetic retinopathy with a pan-retinal photocoagulation. Okay, so in all patients with a non-proliferative diabetic retinopathy, we are not treating with a laser photo. So the treatment of diabetic retinopathy is basically pan-retinal photocoagulation. And while we are not treating all patients with a diabetes or diabetic retinopathy with a prophylactic laser, laser can do harm. Suppose the laser is a harmless thing, we can do prophylactic PRP in all patients. But laser is doing harm to the retina and harm to the visual field. Basically the aim of pan-retinal photocoagulation is to preserve the central vision. The patient is losing the field of vision, but making the patient is blind than losing the field. That is what we are aiming for, aiming with a pan-retinal photocoagulation. You may be thinking that why we are not doing pan-retinal photocoagulation, why we are asking the patient for coming to follow up the patient. This is because the laser is doing harm to the retina. Once pan-retinal photocoagulation is being done, patient can have a loss of peripheral visual field. That I come to the treatment part, when I come to the treatment part. So when you call proliferative diabetic retinopathy, proliferative diabetic retinopathy is characterized by neovascularization of the optic disc, neovascularization elsewhere in the retina, associated with the pre-retinal hemorrhages, vitreous hemorrhage, traction retinal detachment, neovascularization of the iris, angular bone. The last three, if the patient has got the last three, that is traction retinal detachment, vitreous hemorrhage, neovascularization of the angle and iris leading on to neovascular glaucoma, we classify them as an advanced diabetic eye disease. Okay. So proliferative diabetic retinopathy occurs if more than 1/4 of the retina suffers from non-perfusion, and the new vessels can occur over the disc and elsewhere in the retina. So the disc neovascularization indicates more of retinal ischemia. So I told you the treatment of proliferative diabetic retinopathy is pan-retinal photocoagulation. Using several lasers are used, double frequency ER. You can use argon laser, double frequency YAG laser, or a diode laser. The mode of action is, what is the laser doing to our retina? By applying laser burns, we apply beyond the major superior and inferior temporal veins. So that part we are making the coagulating the retina. So the ischemic areas are hypoxic. I told you the hypoxic area and the ischemic areas produces vascular endothelial growth factor. So ischemic areas and hypoxic areas are made anoxic by coagulating the retina. So the entire oxygen available in the retina is given to the optic disc and the posterior pole. The whole area, the other area, we are photocoagulating. So whatever oxygen is there, it will supply the optic disc and the posterior pole. So the visual acuity is preserved, but the visual field is not there. And this hypoxic area become anoxic. And anoxic area doesn't have the capacity to produce vascular endothelial growth factor. So that is the aim of pan-retinal photocoagulation. So the proliferative diabetic retinopathy is again classified into high-risk proliferative diabetic retinopathy and non-high-risk proliferative diabetic retinopathy. So high-risk characters means any new vessels of the disc which is more than 1/3 disc area, or neovascularization of the disc which is less than 1/3 area of the optic disc associated with a pre-retinal or vitreous hemorrhage. And if neovascularization of elsewhere in the retina, it should be more than half disc area along with a pre-retinal or vitreous hemorrhage. Understand? So there are three things. One is neovascularization of the disc, which is more than 1/3 of the disc area. Neovascularization of the disc, if it is less than 1/3, it should be associated with a vitreous hemorrhage or a pre-retinal hemorrhage. And the third thing is neovascularization elsewhere in the retina of more than half disc size along with a retinal, pre-retinal or vitreous hemorrhage. So this is, in this picture, you can see the 4-to-1 rule is not satisfied. You can see only very few hard exudates, very few hemorrhages, not in all the 4 quadrants. So not meeting the other features. So in this patient, you can see there is an extensive retinal hemorrhage involving all the 4 quadrants. So that is the 4 rule. It meets the 4 rule. Okay. So this is again, you can see patient has got, these are all soft exudates, and I cannot see clearly. This is an intraretinal. You can see small blood vessels which are intraretinal microvascular abnormality. Here also you can see small blood vessels. So diabetic maculopathy, I explained it is the most common cause for impairment of the vision in type 2 diabetes mellitus. It may be either focal, diffuse or ischemic. And there is another term which is called a clinically significant macular edema. Again, the management of diabetic maculopathy is either you have to give a grid laser or focal photocoagulation, or nowadays we are giving intravitreal anti-VEGF agents. So this is involvement of the foveal area with a hard exudate. Extensive, you can see, actually we tell the patient it is just like a cancer within the eye. Just like new cells are developing in cancer, new blood vessels are developing in the retina, behaves just like a cancer, because here you can see very extensive hard exudates which involve, this patient may have only hand movements vision and with a very poor prognosis. And this is a fundus picture which shows pre-retinal hemorrhage. You can see the disc is not clearly visible because there are small fine blood vessels all over the disc. So the whole full of the disc is studded with the neovascularization of the disc. Here also this is a pre-retinal hemorrhage, which is a typical boat-shaped hemorrhage because of the extensive neovascularization. You can see in this picture, you cannot make out the retina because you can see the grayish white appearance. The entire retina is detached because of the tractional retinal detachment. In this picture, both these two pictures are advanced diabetic eye disease in the form of a tractional retinal detachment. Again, you can see this is a very aggressive You can see the bleeding from the new vessels from the optic disc. It is just like a tracking. Okay. Here also you cannot see any retina. The whole of the retina is detached. You cannot even, can't see the disc also in this patient because of the extensive retinal detachment. These patients may have a very poor vision like hand movements. These are all fundus fluorescent angiography picture. You can see there is extensive neovascularization of the retina in the form of a fan. So the treatment is laser. I explained the mechanism. The expansion of the laser is light amplification by stimulated emission of radiation. And other treatment in cases of neovascularization or proliferative diabetic retinopathy is in the form of anti-VEGF, that is anti-vascular endothelial growth factor. If the patient presents with a tractional retinal detachment or a vitreous hemorrhage, there is no role for any, if it is an advanced diabetic retinopathy, as in this picture, there is no role for any laser photocoagulation. So that is why I explained in the beginning that the follow-up of the patient is to prevent the patient going into this stage of very advanced diabetic eye disease in which you cannot save the vision. So in that situation, that is in the advanced diabetic eye disease, neovascularization leading on to vitreous hemorrhage, extensive retinal detachment, the treatment is surgery, vitreous surgery, and surgery for retinal detachment, which has got a very, very bad prognosis. And the treatment of macular edema, again, I explained that intravitreal anti-VEGF along with a focal or a grid laser. Mild to moderate, you have to follow up the patient. Again, I explained very severe or severe, consider PRP. That is, if the patient lost vision in the other eye because of the high-risk PDR complications, you can treat the patient prophylactically, and if the follow-up is also not possible. So if the patient is with a high-risk characteristics, PRP at the earliest without any delay, and advanced diabetic eye disease, vitreous surgery. So vision-threatening complications like vitreous hemorrhage, tractional retinal detachment, rubeosis iridis, and neovascular glaucoma, treatment is os plana, vitrectomy, and retinal detachment surgery. Okay, so that is about central retinal vein occlusion and diabetic retinopathy. Okay, any doubt you can ask. Any doubt? I am again calling Leah.
No, ma'am.
So shall I stop? Anybody? I'm calling Leah because I don't remember anybody else's name. I have to find out some other name. Any doubt? Anybody? Shall I stop?
Okay, ma'am.
Okay.
Thank you, ma'am.
I think I can finish 2 more classes. I think I can take tomorrow and day after tomorrow. Okay, is it okay?
Okay, ma'am.
If there is any other difficulty, Leah can inform me. Okay.
Okay, ma'am.
Okay. Send me the attendance also. I think today only 70 students have attended. You are 1-1?
118. Strength is
118.
180. Ma'am, some students are there in YouTube.
Okay, so you can send. Anyway, you are sending both attending Zoom and YouTube, isn't it?
Yes, ma'am.
Okay. Okay.
Thank you, ma'am.